Welcome, dear friends. This is Dr. Jaitly, your cardiologist from New York, on your favorite video site, MuniMeterHealth, which is dedicated to enhancing medical education and patient education to my medical fraternity, dear friends, as well as to my patients at large. Only to improve the clinical outcomes, because we know the clinical results are totally dependent on when you combine medical with patient education. Thanks for being on MuniMeterHealth. I appreciate so much. Now, just a quick few housekeeping rules. So one, this is only a teaching channel. It's not a medical advice channel, just to let you know. Number two, if you're experiencing an emergency, please get to the nearest hospital, call for an ambulance. And if you're in the United States, call 911, dial 911 and get to the hospital, please. And thirdly, for my dearest medical students, I always advise that this is not a substitute to your syllabus. It's a supplement to your syllabus, just so that you know. So without any further ado, let's delve into the short video vignette, which I always present on MuniMeterHealth. What is pulmonary embolism? How do you diagnose it? What are the criteria, and how do you classify? We'll just briefly discuss that, and treatment will be on another video, I'm sure, I promise. Okay, so let's do a quick here. There are several ways to diagnose pulmonary embolism, just so that you know. We'll first define what's pulmonary embolism. Well, let's understand how the lungs work. Here's my favorite schematic, which I normally draw. And this is your chest. Okay, these are your lungs. And obviously, we're going to show the heart in the middle, which will be more pointed towards the left, as you know. And here comes out your aorta. This is the big fat hose that's supplying the rest of the body. So this being the right lung and this being your left lung. So now what happens is, over a period of time, if you were to develop a clot somewhere within the pulmonary artery, now we got to show the pulmonary artery here in the blue, because that's carrying deoxygenated blood. So here we go. Okay, these are your pulmonary arteries, which originate from the right ventricle as they emerge, and they're bringing deoxygenated blood to the lungs, and they supply smaller arterioles here as we go along, and then later on they become alveoli, if you will. Now, obviously from here the capillaries will form, and these capillaries we are showing in these colors here, and then eventually all of this will merge to become pulmonary venules, which will be in the reds, and these red will eventually pour into the left side of the heart. There are 4 sets, by the way, just so that you know, and they pour into the left side of the heart. So what are pulmonary arteries carrying? They're carrying deoxygenated blood, friends. Okay, so very low in O2 but high in CO2. And what are pulmonary veins bringing the to the left side of the blood? It's full of oxygen, exactly, and very little CO2. So it's mainly oxygen it's carrying. So the pulmonary veins, they are bringing blood to the heart on the left side. Pulmonary artery is carrying the blood to the lungs from the right side, just so that you know, and they're represented in the blue here. So now a clot can form from the legs, for instance. Now we'll draw the leg here, for instance. I'm not a great schematic person here, but just so that you know, I'm just drawing something here for you guys. Okay, now this being your leg, here's your calf, and maybe perhaps leg, and then this comes out the foot. So what's happening is, well, you get the idea. These are the veins. These are femoral veins and deep veins, etc. Popliteal veins down here because of the popliteal, and then the tibial veins down here. Okay, and these are your dorsalis pedi veins as you go along. So this whole tributary of veins that are constantly bringing blood back to the heart, remember, this is rich in CO2, that's being brought to the right side of the heart here. Somewhere along the line, if the person is immobilized, for instance, after surgery, or if the person is actually, say, has had a knee replacement or a hip fracture, you know, classic cases where patients are prolongedly immobilized within the hospital, heart failure patients, or very, very frail, ill patients, cancer patients, for instance. So and of course the long flight, somebody's taking a long transatlantic flight. That's my favorite flight, going to Europe or to India. So I always say that, you know, you got to move around within the flights, because if you're sitting in one coach seat, it's called economy coach class syndrome, and if you sit for too long, the chances are your veins will be clotting, and as a result some of the clots can dislodge, and the next thing is you have a PE called pulmonary embolism. Very, very dangerous, very, very fatal condition, my friends. So just remember that. So try to move around within the coach seat if you can, every hour, every 2 hours. Do a little bit of yoga if you can, or paddle your feet, I always say, to mobilize this circulation so that the blood does not clot. So that's one preventative way. But nevertheless, now if the clot, say, does form, what happens next is the clot can mobilize. And if the clots can mobilize, these are the blue clots that I've shown here. If these clots, they mobilize, the next thing is they're in the right atrium, right ventricle, and they get dislodged into the pulmonary artery. Now, when the pulmonary artery gets blocked, what happens is the next thing is you have a small area of the alveoli or the capillaries which do not perfuse, correct? Because ultimately alveoli are getting perfused by these small pulmonary arterioles. So now you have multiple showers of pulmonary emboli, if you will, all around in the lungs in different areas. So you have areas which are hypoperfused and yet they are being ventilated. So there is a mismatch here, you see. So the ventilated, why? Because you have the trachea. Let's show the trachea here, for instance. Here's your trachea, which is your air windpipe, if you will, and that divides into bronchioles, and that is giving all these wonderful alveoli the fresh oxygen. So it's bringing oxygen here because you breathe in oxygen. So all of that oxygen is being ventilating these alveoli, but they're not being perfused, especially this area, and this area where the pulmonary arteries have been blocked, and that's called pulmonary embolism. Okay, so the arterial clot that's formed within the pulmonary artery, may it be the big artery or the small artery or the arterioles, regardless, it's all pulmonary embolism, based on which we decide whether they are small, medium, or large pulmonary embolism cases. Okay, so now you have a mismatch, and the mismatch is defined as a VQ mismatch. Ventilation is good, but perfusion, which is considered as Q or VP mismatch or VQ mismatch, we call it mismatch here. Okay, so the quotient or the perfusion quotient is very, very low here. So it's not being perfused but being ventilated, and that's useless because you can ventilate an airbag and not perfuse it. What's the point? You want to actually perfuse it so that this way the blood can actually pick up the oxygen, send off the CO2, so the CO2 is all exhaled out, whereas the oxygen is going in. So oxygen is going in and the CO2 is coming out, and that's the whole idea of ventilating and perfusing, so that this way we have a nice balance. But the moment the balance is disturbed, or it's called the mismatch, that's where the problems arise. Okay, that's where the patients become more breathless, become more tachycardic, or heart rate goes up, and of course they may have chest pains because they have a pleura which is getting rubbed here because of the inflammation, secondary to pulmonary infarctions that develop, or pulmonary necrosis, if you will. So the pleural rub is very, very sensitive. It has, the pleural surface is very, very sensitive to pain, and these are very sharp knife-like pains that can occur each time the person decides to take a deep breath. Okay, so that's called the pleuritic pain. So what have we learned so far? The history will be the following: prolonged immobilization, symptoms of any recent surgery, a fracture, an illness, a long flight we just talked about. DVT and pulmonary embolus in the past, you have to give extra points to diagnose that. So this is all part of the history, folks. You got to take that. And a history of cancer recently or within the year, whether actively being treated, or even if it's dormant but within the year. And then you have a unilateral swelling. Now that's a giveaway. If you have a unilateral swelling which is painful, that itself gives you highest points for favor of pulmonary embolism, especially if patients presenting with breathing difficulty. You must consider pulmonary embolism. The second thing is the hemoptysis, that is coughing up blood. If you're coughing up blood, that's not a good sign. Okay, so that implies that some necrosis has occurred somewhere, and so that's again a heavy pointage there. Shortness of breath, as I said, SOB, cough, and pleuritic pain. Now on examination, you'll find the heart rate will go up. It'll be more than 100. As I said, tachypneic means the respiration normally is about 16 to 18. Here it could be 30. So it could be 30, 25, anything more than 18 will be tachypneic. And dyspneic because they're very, very difficult to breathe. They have experienced difficulty in breathing. And of course, there might be wheezing and pleural rub we just talked about, which is a very sharp pain under the pleural surface. Now that can be sometimes referred to the shoulders, etc. If it's the diaphragmatic pleural surface, this is diaphragm right here, or it could be from within the ribs here, and then it can be referred to the local area where exactly the rub is, here or here or here, wherever the inflammation is, depending underneath the surface of the pulmonary necrosis. Now, how do you classify? Well, the suspicion based on the diagnosis, then you say, okay, well, there's a low probability, there is an intermediate probability, or whether there is a high probability. If it's a high probability, you can straight go ahead and confirm it with a CTPA. It's called, you're doing a computed tomography, a CT scan of a pulmonary angiography. Remember that, specific for pulmonary angiography. So you actually see the pulmonary artery and you see where the clots are. If there are any clots, then you'll define that and say, okay, now we have confirmed the diagnosis of, because it is a high probability you did not order a blood test. You don't need to order a blood test. But you can order a blood test only when you have a low probability or an intermediate probability, and the test is D-dimer. So when you do a D-dimer, it's a blood test which is normally present only when you have PE, when you have PE. So if it's a low probability, the chances are it'll be negative, and then you stop. You do not do any further testings. You can do other testings like echo, etc., but I don't think you need any radiological procedure. Again, but if the low probability, the test comes back positive, then you must order a CTPA, because your probability of finding PE was low, but the fact is that you have a D-dimer now which is positive. Therefore, you must confirm that with CTPA, because you're committing somebody for an anticoagulation for 3 to 6 months, maybe perhaps a year, depending upon what the situation is. So this is one of the things that I'll always say, that if your D-dimer is positive in a low setting, then CTPA is a must, and you must do that. Now, in an intermediate category, it's a little tricky here. Now, D-dimer, you could do a test here. Obviously, you're going to do a D test. But the fact is that if the CTPA is positive, or sorry, the D-dimer is positive, then you can do a CTPA, and CTPA, depending upon what you see, positive and negative, you can decide to treat. If it's positive, you go ahead and anticoagulate this person. Otherwise, stop right there. Whereas the D-dimer, if it is negative in an intermediate probability, where the score is about, say, 6 to 10, out of these. Now remember, all of these are given a scores here. Now people have used Wells criteria, named after Dr. Well, or it is being used as modified Geneva criteria. So basically, modified Geneva incorporates age as well, age more than 65, whereas Wells criteria does not involve the age. But I think age 65 is very important, and therefore modified Geneva is the way to go right now, and that was published in 2006 in JAMA. So just so that you know, you can read the details there. But the very fact that if you have all these criteria, each of these criteria are given some points, say 3 points, 6 points, 9 points, depending upon what the pointages are. You can look it up in the details on that article. But the fact is that once you have, say, a ratio, if it is more than 6 to 10, then you're looking at the intermediate category. If it is less than 4, then you're looking at low category of low probability of PE, but the high is more than 11. If you have more than 11, then that's a high probability of PE as is. So depending upon how many did you make out of these criterias, you will determine what your categories would be. So you're depending upon low, intermediate, or high probability where you belong, then you decide what to do with the D-dimers. Okay, so in a nutshell, you've learned all the history and the complaints that these patients present with, and of course what their physical findings will entail. But the heart rate is a very, very important. You have to give a lot of points to it. Hemoptysis, if it's present like a cough and blood, you'll have to give a lot of points to it. Unilateral swelling, especially if it is painful, you can say a tender swelling in the legs. These veins, by the way, they can be very painful also. So these veins are painful, and you could test that. So there's a point for that as well. So these veins could be pointful. You could have edema here, a swelling in the legs. So that I didn't point it out here, but edema and pain in the legs. Very, very important. So these are also, every one of these categories is given a point, and depending upon what the points are, how many points you accumulate, that will determine what category of suspicion you have, whether it's low, intermediate, or high. Okay, well, I thank you for your attention, and hope this was helpful. Again, these are very short video vignettes, primarily to give you a quick brush up before you take your tutorials, before you take your exams, before you go for your bedside clinics, and of course before you go and see a patient if you were to making rounds the next day. Okay, so thanks again, and again for the patients, it's a very, very helpful, because I'm sure they would like to know what pulmonary embolism is, how to treat. Everything is treatable, but the very fact is the suspicion has to be there by the doctors, and if they apply certain tests, you have to go for these testings also. This CTPA, remember, it's a radiological test, and therefore pregnancy should be avoided for any of these testings, and it's not an ultrasound, it's not a safe test, so you have to give a huge guard to all these pregnant patients, because otherwise you'll be just irradiating for nothing. You don't want to do any harm to the fetus or the intrauterine fetus. Okay, so very, very important. Again, CT should be avoided in pregnancy, but the fact is that if you have to do the testings, you can do the D-dimer test, and hopefully arrive at some reasonable diagnosis in those cases. Again, once again, thank you and stay well, and of course keep watching MuniMeterHealth until my next video, which is